Miigwech. So let's open it up to the group. Cresta is going to be speaking with us today for her presentation. And go ahead and introduce yourself.
Okay, thank you everyone for inviting me today. I'm so honored to be a part of this group for today's ECHO. My name is Cresta Jones. I'm maternal fetal medicine and addiction medicine at the University of Minnesota and have had the pleasure of working with Dr. Robbie and your team before. And I'm going to talk a little bit today about the unique aspects of treating opioid use disorder in pregnancy. So thank you for letting me join you.
Thank you. Stephanie, do you want to go next?
I'm so sorry, I could not find the unmute. Hi, I'm Stephanie Dean. I work at Hennepin Healthcare and I oversee professional provider development. So the CME world is where I live in.
Great, thank you. Corrine?
Hey, yeah, my name is Corinne Turback. I work with spiritual health services at UMMC, primarily supporting patients and families in the NICU and OB labor and delivery.
Great, thank you. Haley?
Hi everybody, my name is Haley. I'm a public health analyst for the CDC Foundation's Overdose Response Strategy. Thanks for having me.
Great. Jim?
Ben Voren, I'm a family practice doc at Bethesda Clinic in St. Paul.
Welcome. Tessa, do you want to go next?
I'm Buju, Makadeba Naisikoin Indigenous Animki and Doran. I am working at Northwest Indian Community Development Center here in Bemidji, Minnesota. I'm originally from Michigan. I'm Ojibwe and Odawa from that region. And our center, we do a lot of reentry work. People who are coming out of jails and prisons, and our relatives who are trying to establish housing and rejoin with their families, and that kind of work. And I work as an Anishinaabe cultural educator there. My background is in Indigenous studies, and I occasionally do internal evaluations. So I'm here to learn.
Thanks for joining us. And I'm actually from up in that area. I'm from Red Lake, so you're in my home area. Welcome. Erin, do you want to go next?
Hello, everybody. My name is Erin Nixon. I am the Integrated Behavioral Health Coordinator here at NAC. Thank you.
Thank you. Shelley, do you want to go next?
Yes, I'm excited. This is my first ECHO with this group. So I've taken down Tessa's name because I'm from Bemidji, and Laurel, I wrote you down as well. So I am the new treatment coordinator for Sanford, Bemidji's MAT program. And then in a month or so, I will wear the new hat as a provider, as a nurse practitioner, providing those services. So really working to kind of eliminate silos in the northern tier of Minnesota to kind of coordinate care and just cohesify things. So really excited for this opportunity. I have a long 30-year history in OB, so this is exciting for me, this particular ECHO topic, which I heard about last week at just the regular Thursday ECHO from Hennepin County. So excited about this focused group.
Great, thanks for joining us, Shelley. Jim, do you want to go next?
Yawaskino. My name's Jim. I am with the Iowa Tribe of Oklahoma Perkins Family Clinic Behavioral Health. I'm a peer recovery support specialist and a case manager. And right now I am working to help bring integrated services into the picture with Matt, and also doing a lot of outreach to reduce stigma. It's good to see you all.
Great. And there's another Jim on the line as well. Do you want to introduce yourself? Van Voren?
Oh, I think he already did.
Oh, okay. And then we have a number here with the last numbers are 0546. We can't hear you if you're talking. If you could unmute yourself. Okay, we'll come back. Jennifer, do you want to introduce yourself?
Hi, I'm Jen Nelson. I'll be at the Duluth Family Medicine Residency Program.
Great, thank you. Abby?
I'm Abby Anderson. I'm a family practice PA at the Minnewawan Clinic in Cloquet.
Great, welcome. Heidi? Okay, we're not hearing you. I don't know if you're on mute.
Hi, sorry, I was on mute. I'm a social worker. I work with women exposing their babies to chemicals, prenatal exposures.
Great, welcome. Jack John?
I am Jack Loftus. I'm an alcohol and drug counselor at Native American Community Clinic.
Great. Jean?
Hi, great to join everyone. I'm a scholar practitioner in social work and anthropology, working to advance health equity, and currently at a managed care organization in Minneapolis.
Great, thank you. Jennifer? You may need to unmute your mic.
Not sure if there's more than one Jennifer, but I just introduced myself a minute ago. I just didn't have my video on.
Katie, can you go next? All right, and we can't hear you, Katie. Okay, Kim, can you go next?
Yeah, I'm the RN care coordinator at NAC, or for our OB patients who are in our MAT program and with other substance use.
Thanks, Kim. Sheena?
Hi, I'm Sheena. I work Marshall County, Minnesota. I'm a children and adult mental health social worker.
Great, thanks for joining us. Molly?
Hi, I'm Molly Stapleton. I'm a family practice doc up in Fond du Lac.
Great. Marissa?
Hey, I'm Marissa Anawash. I'm a nurse with NAC.
Hi. Pamela?
Pamela Hughes, Voice for Tribal Government, Program Director for our Substance Use Program and our 20-unit supportive housing for homelessness.
Great, welcome. Shelley?
Are there two of us? I did speak.
Oh, okay. There might be. Let's see here. Susie?
Hi, this is Susie Emmert from Hennepin Healthcare and Advocacy and Public Policy. Just here to listen. Thank you.
Great, welcome. Valerie?
Hi, I'm a person in long-term recovery, and I am a certified peer recovery specialist and a grad student at the U of M in addictions counseling. Thank you.
Great, welcome. Zoe?
Hi, I'm Zoe. I am a nurse that works with Michelle and Dr. Robbie at NAC, and I do MAT.
Great. Tessa? Okay, I think I may have got everybody then, although my participants are kind of hopping around, so it's kind of hard to see. If you haven't introduced yourself, go ahead and do that.
Hi, I'm Artie Prasad. I'm the Department Chair of Internal Medicine at Hennepin Healthcare, and I'm also the executive sponsor for Project ECHO at Hennepin Healthcare.
Great, welcome.
Hi, I'm Sheila Rasmuslowski, and I'm a child protection investigator for Polk County.
Great. Anyone else? I'm just kind of glancing through to see if I missed anybody. There was the person with the number 0546.
I'm Allison Quincer. I'm also with Marshall County Social Services, and I do adult and children mental health case management.
Excellent. Great. I think we got everybody.
I think so too. That took a while. That's awesome.
Great. All right. If you didn't get a chance, go ahead and type your name and information into the chat. All right. Can we pull up the PowerPoint?
I actually have it on my screen with a couple of changes too, so let me know when you want me to pop up my slides.
Okay, so we'll do some of our intro slides and then we'll switch over to you in a minute.
Sounds great. Thanks.
Okay, great. So you were able to, we had Donna LaChapelle give our prayer this morning. Thank you so much for that. That was great. We got to hear from everybody with the introductions. And then we're going to go through our Zoom guidelines, and Michelle Cochran will share us the announcements. And then we'll go over to Dr. Cresta Jones for our didactic on pregnancy and OUD. And then we'll close out with Michelle. Thank you.
We'll actually have a case presentation and then we'll close up.
Oh, great, great, great. So if you could all go ahead and type in your name, title, organization, and email, that will allow us to follow up with you and get you future communications about upcoming echoes, and also to send you our assessment, the follow-up post survey, to get some feedback from you, but also if you want CEUs. And then if you could just right click on your screen and put your name in, if you can, on your image. I think most people have, so thank you for that. And we want to make sure everybody has a good experience, and we enjoy seeing everybody's faces, and it helps us to remember each other. So if you could turn on your camera, we appreciate that. And then just go ahead and mute yourselves when others are speaking. And we may mute you, please don't be offended. We just want to make sure that we're not having any feedback. And then there is a hand raising function that you can use, and we'll keep an eye on that. If you do have a question, you can also write them in the chat. And we will not be using any protected health information, just a reminder to respect people's privacy. All right, Michelle?
All right, so for announcements, as usual, just a reminder that we meet the first and third Wednesday of every month from noon to 1, and that's Central Standard Time. We know that's over lunch, so feel free to bring your lunch, cup of coffee, whatever, and join us. We have a couple sessions listed here. So next one is going to be September 2nd, and we're going to be talking about toxicology testing and that sort of thing with Kayla Wong. And then on the 16th, NAC staff will be talking about outreach and syringe exchange services. Another thing I want to kind of mention here is NAC is going to be starting an LGBTQ Two-Spirit Wellness group, and that's going to be on Fridays from 3 to 4:30. Interested participants can call our behavioral health front desk at the number here on the screen, or you can just call our main number and get routed to them. Case presentations or clinical questions. As usual, we welcome your difficult or memorable or really awesome cases. So you can fill out a case presentation form on the hennepinhealthcare.org/echo site. That gets submitted to us, and then we just have you kind of discuss your clinical question or your concerns during a session, and get some feedback from everybody, and that way we can learn together. Continuing education. CME credit is available. As long as we have your email address, you will get a post-session email with a survey, and that is how you can get your CME credit. There is going to be a half and half buprenorphine waiver training coming up. This is being hosted by Hennepin Healthcare. It's going to be Thursday, October 29th from 1 to 5. Half and half, meaning half is in person, half is online as a self-paced, learning session. So PAs, nurse practitioners, physicians are able to join. It's presented via Zoom. There's no fees. If you have questions, you can reach out to Elizabeth Ryan. So these 4 hours would be done via Zoom, and then there'd be another 4 hours or 12 hours that you would need to do on your own. And so now, Cresta, I'm going to stop sharing, and now you can share.
Great, thank you, Michelle. So Dr. Cresta Jones is a maternal fetal health medicine. She works with high-risk OB patients and addiction medicine. She's also an associate professor with the University of Minnesota. Welcome.
Thank you. And today I'm going to distill down everything you need to know about pregnancy and opioid use disorder into this short period of time. So I've tried to summarize ways that this disorder is a little bit different and the things that I kind of see my patients and families most challenged with. So I don't have any disclosures, and I always have to remind people that what we talk about as far as management of opioid use disorder for pregnant people is not specifically FDA approved. So I think we kind of went over the objectives already. I think the main thing I'd like to do is for you to identify where this may be different than caring for non-pregnant people and their families. So it gets very complicated when you're dealing with an individual who is pregnant and suffering from opioid use disorder because you have conflicting interests. You want, and those of us who care for these pregnant people in the long run want to maximize everything we can for long-term recovery, balancing the focus to minimize complications for the infant. And really, we live in a community and in a world where the social context does not promote pregnant individuals from disclosing to us that they are experiencing substance use disorders. There is a lot of stigma, there's a lot of guilt. There remains a belief in society that this is a lifestyle choice or a moral failing. And all of us who are attending this today fight against this limited understanding of addiction as a chronic medical condition. And we live, especially in this state, among others, with the criminalization of a medical disorder in pregnancy. And we'll talk just briefly about that a little later as well. So this is kind of the most recent data we have. This is all women who presented for treatment over about this is 7 years of data here for treatment for substance use disorders, and in particular opioids in Minnesota. And the blue bar at the bottom shows those women who are identified as pregnant when they entered treatment. And this is just looking at that general trend. And we can see that the amount of pregnant people who are entering treatment, identifying opioid use disorder as their primary medical condition, has over the last few years been going up. And I just want to put this in here because this is something that I think frustrates a lot of us, and Dr. Robbie and I talk a lot about this, is we reside in a state which has a requirement for mandatory reporting in pregnancy. And essentially what that means, if it's kind of a lot of language, but what it says is if you know or have reason to believe that a woman is pregnant and has used a controlled substance for a non-medical reason, you are required by law to report this individual. And when you look at this in the context of the stigma, they put, in any way that is habitual or excessive, again, making this seem like it is a habit that can be easily broken and not a medical condition. And I draw attention to the part that's underlined, is that if a woman is using THC products or alcoholic beverages, we are exempt from reporting them if we know she is getting prenatal care. Now, again, we can talk about how access to care may cause inequity for this type of legislation, but I just want those, especially who are new perhaps to the state, to be aware of the legislation which confines some of the way we practice. So how is pregnancy affected? So this is looking primarily at what the pregnant individual will have if they have untreated opioid use disorder. So these individuals are often exposed to infections, whether this is from, non-sterile injection supplies, things like osteomyelitis, heart infections, and not to mention other infections such as sexually transmitted infections, which may be acquired through risky behaviors. There's an increased risk of injury, of course, overdose, which affects both pregnant and non-pregnant individuals. And when we look specifically at how a mom might be affected, the biggest concerns are an increased risk of preterm labor and preterm contractions in particular when women are having significant withdrawal symptoms. And placental abruption has been associated with untreated opioid use disorder, although often we see that more with polysubstance use disorder. Hang on one second. Okay, there we go. Oops, let's go back. So when we look in particular at how the baby is affected, some of the infections that a pregnant individual might experience can cross the placenta, things such as HIV. There is an increased risk in pregnancies with untreated opioid use disorder for preterm birth. Babies that may not grow as well. And the thing I think that we spend the most focus on with pregnancy is neonatal opioid withdrawal syndrome. So why do we treat pregnant individuals? Well, we know that treatment for anyone prevents withdrawal, cravings, relapse risk. And in obstetrics, it has been shown to improve adherence with prenatal care. And I think something that's important to emphasize is that studies have shown that even in individuals with ongoing non-prescribed opioid use, if they are adherent with prenatal care, obstetric complications decrease. And so I'll get back on my soapbox just really quickly. In a state that penalizes individuals who identify to their providers that they're suffering from substance use disorders in pregnancy, this may actually create a barrier to something, engagement with prenatal care, that may actually improve obstetric outcomes, even if an individual is unable to engage with substance use disorder treatment at that same time. So what do we treat women with? So the two recommended medications are very similar to the first line for anyone who's not pregnant, which are methadone and buprenorphine, although the one difference is the sort of experts who focus on this identify that buprenorphine monotherapy has been the best studied. And so we'll talk mostly about those two, but I just want to provide a little information on the alternative treatments that might be considered, because those are also things that we're seeing individuals come in with and perhaps have a preference to remain on during pregnancy. So just as kind of what the experts tell us is that opioid agonist pharmacotherapy, which is buprenorphine or methadone, is really the recommended therapy, both from the Mental Health and Substance Abuse Service Administration and also from the sort of governing body of OBGYNs in the US. So the advantages of methadone are that it's been around for a very long time. It's been used in pregnancy for a very long time. It has a long duration of action. And we do see higher treatment retention for individuals who are pregnant and are engaged in methadone treatment. We also know that it has been shown to reduce the risk of complications such as suboptimal fetal growth, infection. It engages women in prenatal care and reduces the risk of preterm birth. The disadvantages that I see often, and in particular are highlighted in a pandemic, is it can be very difficult to access and can't be accessed at all through your OB provider, meaning that individuals will have at least 2 clinical sites that they will need to access. They'll have to go to the clinic where they're getting their methadone on a daily or most days of the week basis, and then also go to another provider for pregnancy care. The withdrawal that we see in babies can tend to be longer and more severe. And there are drug interactions with methadone with medications that we use very frequently in pregnancy. So specific antidepressants, nifedipine, which is one of the first line treatments for high blood pressure and for preterm contractions, and also with some antibiotics. Some of the clinical pearls, I think, for us is that I've had numerous patients that the reason that they identify that they're pregnant is they've been on the stable dose of methadone forever, and all of a sudden they get withdrawal symptoms. And that's because your metabolism increases and the volume of distribution increases. So it is very common to see individuals needing both an increase in their dose because the volume of distribution is increased, but also splitting of their dose because the metabolism is faster. This can occur at any time in the pregnancy. And really another sort of pearl that we found is individuals will often want to wean off their medication or to wean down, but in general, higher doses are more likely to lead to less illicit substance use during pregnancy. So the medication that I have the most experience with in recent years, and I think for everyone at the NAC as well, is buprenorphine or Subutex. And so we know there are a lot of advantages to using this medication. It can be prescribed at the same site as obstetric care, so you can really batch the healthcare and not have to visit frequent different clinics during your pregnancy. It has been around long enough now that we have some very good pregnancy and breastfeeding safety. Although the babies tend to have neonatal opioid withdrawal at the same rate, it tends to be shorter and less severe if pregnant individuals were maintained on buprenorphine. And we do now have long-acting formulations, for example, the depot injections. So individuals could actually use this medication with infrequent visits. And I apologize, I'm at home and I have a little barking dog in the back. Similar to methadone, buprenorphine may also need increases in dosing and split dosing during pregnancy as well. So the disadvantages are we do not have a lot of compelling data on long-term childhood, so going into adolescence and adulthood for individuals whose mothers were treated with buprenorphine during pregnancy. And there are risks to having to go into withdrawal in pregnancy. So a challenge we often see is individuals who present for treatment would really like to be on buprenorphine for a whole host of reasons, but don't do well when they develop withdrawal symptoms or they start having contractions or some other type of pregnancy complication related to going into the withdrawal needed. And so there have been discussions in some of the women's addiction groups that I work with through ASAM about the possibility of microtitration. And I just put a question mark there as something, it's also known as microdosing, for starting buprenorphine as an area that really needs to start being investigated for women in pregnancy, because I could imagine not having to put them through significant withdrawal might actually improve our ability to initiate and engage treatment. The head-to-head studies of buprenorphine and methadone in pregnancy did identify slightly lower retention in treatment. So Suboxone, I think this is those of us who are prescribing, this is the medication we use most frequently in our non-pregnant patients. And you will see more and more pregnant individuals coming in who are on Suboxone and are interested in continuing this. So Suboxone has naloxone added that was added many years ago to help reduce the risk of diversion and perhaps less diversion, but incorrect use of buprenorphine. It's actually minimally absorbed if you use it correctly. And so there is less pregnancy experience because there was concern if it were systemically absorbed, it may cause untoward effects for the developing fetus. But really, pregnancy experience is increasing. And if you do a lit search for, combination therapy in pregnancy, we really have some robust data, especially on pregnancy and with for neonatal outcomes. The expert panel that was convened to address this in pregnancy had found that really this should be based on an individual discussion. And certainly this medication has been found to be very safe to transition back to during breastfeeding. So Vivitrol, I think most of us are familiar with this medication as well. This is an opioid antagonist and is typically used as a longer-term injection after withdrawal has been completed to avoid the effects of opioid agonists or pure opioids if used during recovery. The biggest issues with Vivitrol is we do not have a lot of safety data on the use of this medication in pregnancy. We have some newer or less robust data on the implant, primarily out of Australia and New Zealand, which suggests that it's safe, but there are concerns about problematic pain management at delivery. So if this is blocking opioids and you have a C-section, it's also going to block the effects, the analgesic effects of that pain management at delivery. So if you have a patient who knows she's going to need a C-section, this may be very problematic as far as the ability to keep her pain well controlled at delivery. And we really don't have a lot of breastfeeding safety data on this as well. So really the jury is still out on should this medication be used in pregnancy. There are some registries which are starting, and I do think that this is something that we're going to hear more and more about. And I think I've certainly seen patients who've come to the clinic hoping to remain on this medication during their pregnancy. So medically assisted withdrawal, what that really is individuals who do not want to remain on medication during pregnancy. It is a medically supervised way to wean individuals off of opioids. So most of the times when this is described, this is either in a day program or in a hospital setting where individuals are on methadone or buprenorphine and are slowly weaned off. So the advantage of this and the hope is that if women or pregnant individuals are able to be maintained off any type of chronic opioid treatment during pregnancy, that this will minimize the risk and cost for neonatal opioid withdrawal. And I think for me, I have to think about the disadvantages. So when you're focusing on the risk and cost of the neonatal effects, how do you put a value on the real complications and risks for that pregnant individual if they relapse or they're lost to treatment during their pregnancy? So the disadvantages include very high relapse to non-prescribed use. Many individuals have left during the withdrawal process. Individuals who had completed the program did still have neonatal withdrawal, and whether that was ongoing non-prescribed use or some sort of withdrawal that persists that we don't really understand. And the most frustrating for me is that we've seen a lot of these articles recently, and very few, if any of them, address the long-term maternal outcomes. And when we are looking at the life course of an individual, I don't think I can recommend this treatment if I don't know what's going to happen to that woman or that pregnant person or their family during their life course. So at this point, ACOG really only recommends this if you have an individual who says, you know what, I will not be on any kind of medication treatment during my pregnancy, or I have no access to this. And that will involve often, like I said, very lengthy, high intensive care as this person is weaned off of their medications. So I want to talk a little bit about some of the biggest questions that come to me when patients present for care or come for a consultation, and that's really how is opioid use disorder going to affect their pregnancy? How is their pregnancy going to affect their opioid use disorder? And what do we need to pay attention to that's going to be a little bit different? I think one of the things that often happens is individuals are seeing a pregnancy provider elsewhere who just doesn't feel comfortable kind of looking at the nuances or the special issues that need to be recognized. And some of these things are just for our individuals affected by opioid use disorder in general. So you need to recognize and treat psychiatric illness to help individuals engage in addiction treatment. So screening for any type of mental health concerns, encouraging access to treatment. Most psychiatric medications can be safely continued in pregnancy. And in fact, when individuals discontinue their meds because they're worried about the effects to the baby, there can be an increased risk of adverse outcomes from that. So women with severe depression or anxiety that's untreated are actually at a higher risk of preterm birth and smaller babies, and that risk is reduced when they're on medication. So it's certainly something that we really prioritize when we're looking at optimal outcomes for our pregnant individuals. Tobacco consumption. So if you look at some of the literature, 85 to 90% of pregnant individuals diagnosed with opioid use disorder continue to use tobacco during pregnancy. And we know that this can significantly impact how the pregnancy goes. And so incentive-based treatments in some areas, I know we had a very successful program called First Breath when I worked in Wisconsin, have been shown to help decrease tobacco consumption in pregnancy with a goal for abstinence. But I've also taken sort of a harm reduction focus in looking at some motivational interviewing skills on heavy use versus lighter use. So if I've got individuals that are smoking a pack or day or more, can we look at what might need to happen to get them down to a goal of a half pack a day? We know that if women or pregnant individuals are able to decrease their cigarette consumption during pregnancy, that this leads to improved outcomes for the neonates. And I also emphasize that combined nicotine replacement therapy, which is what is usually deemed to be the most successful for tobacco cessation, can be safely used in pregnancy. And we do encourage women to use a combination of sort of a basal rate with a patch that lines up with how much tobacco they've been using, and then to also use things such as lozenges or inhalers if that's found to be beneficial for them as well. So one of the most important parts of my care for pregnant individuals with opioid use disorder is managing expectations. There's a lot of disinformation, there's a lot of fear, there's a lot of distrust. And a lot of that distrust is validated by prior experiences that that individual has had with the healthcare system or that their family or community has. And I acknowledge that there is a lot of structural racism that's built into our healthcare system, and in particular in addiction medicine, that needs to be addressed and dismantled as we move forward. But I think in the immediate time, I try to talk with patients about, hey, here are the things that are going to come up as obstacles for me to truly provide you with the best care during pregnancy. So I am bound by state law to provide a report if you have active substance use, or I suspect you of active substance use at the time of your visit to me. Now, we can talk for hours about what the interpretation of that might mean, and different ones of us see it in different ways. But I think that patients need to be aware that often the reporting that occurs is not happening because I am trying to make things more difficult, but because I'm required by law. But I think being very open and honest about, hey, this is what we're bound by. How can you and I partner to work through this, and being honest about that at the very beginning. We try to batch visits. So if someone's going to come see me for a visit to talk about medication use in pregnancy, can I do their ultrasound at the same time? Can they meet with somebody from pediatrics to talk about what's going to happen when baby arrives? Can we do that all at one time? Or if that's not convenient for the patient, can we separate that out to shorter visits? In general, I recommend both an initial ultrasound for fetal anatomy, and then also we check the growth at about 28 and 32 weeks, with potentially more ultrasounds if a patient's really struggling with recovery. So if we are, if they just are having trouble getting to their medication treatment prescriptions, or, have non-prescribed use, I like to see them more often just to check in, see where they're at, see if they have, naloxone available, see if they have any questions. And I think sometimes the reassurance that the baby is doing well can be very helpful for these individuals. I like to talk to them a lot about the management of pain surrounding delivery. I acknowledge that these individuals have not been treated equitably in the past, and there remains stigma in the hospitals. And I encourage pregnant individuals to advocate both with me and with their other providers if they have had experiences where they were not treated in an equitable fashion. If they are worried about what's going to happen with a baby, if they haven't had an experience with an infant who's at risk for opioid withdrawal in my system before, I also offer them the opportunity to talk to somebody from pediatrics about what that program is going to look like. And I think one of the most important things, and something that we are lacking in particular in obstetrics, is access to funded peer recovery coaching and pregnancy and parenting groups, which are focused, if wanted, on families that are experiencing opioid use disorder, where they can be honest, where they can talk to individuals who have met the same barriers as they have, and really have that access to individuals who've been through this and can support our families. On labor and delivery, we still have a ways to go with consistent standards in Minnesota. We do have a toolkit that the Minnesota Hospital Association has developed, kind of trying to standardize what we use. But I think the biggest things that I always try to impress upon patients and their OB providers, if they don't have experience in this area, is a patient should stay on their outpatient medication, and they should take it at the same time every day in the same dose, whether they're in labor, whether they just had a C-section. That is managing their opioid use disorder and will not manage their pain, but certainly their pain will be much more challenging if they're not getting their buprenorphine at the scheduled times they take it at home. And if I have a patient who sort of takes it as an ad-needed kind of medication, well, I usually take 8, but sometimes I just take 6 if I'm feeling better. I say to them, think about what you would need to be sort of stable from a treatment perspective when you're in the hospital. And if that really is taking 4 twice a day, I need to have that documented so that we can get you adequate treatment when you come in labor. We encourage an early epidural if that's something that individuals with labor are interested in. And we really adequately educate the staff that, there's very good evidence that individuals who are on either methadone or buprenorphine treatment to assist with OUD, they're going to need more pain medication. Their receptors are changed, and they will need higher doses of medication. And to get away from this drug seeking if you have pain, and get to every one of our patients is entitled to adequate pain control for delivery. I try to have a contingency plan for patients, especially if they know they're going to have a C-section, if they have had struggles with opioid pills in the past. I try to make a plan where if they really struggled with oxycodone, could we use oral Dilaudid? Is there a pill that might have less risk for relapse or non-prescribed use for that patient? And I'd like to have that in the record. So we say if she needs a C-section, we would like to send her home with oral Dilaudid, please avoid oxycodone. And this isn't something that I say, hey, you had a problem with oxycodone, we will decide to do this for you. It's a, what do you think would help you if you have a C-section to help avoid a relapse because of the medications that we give you. We encourage all of our individuals to breastfeed. This is supported by OBGYNs, pediatrics, the American Breastfeeding Association, with very few contraindications. So really ongoing illicit use, active HIV, hepatitis C if they have bleeding nipples. There's really few contraindications. Now that's not to say that individual hospitals or hospital systems may have policies that put up barriers to our patients, and that does need to be addressed. So I do think being aware of what the policies are, making your patient aware of those, especially if they intend to breastfeed, so there isn't this unexpected arrival of a lactation consultant who says, I don't think you can breastfeed your baby in our hospital. That has been problematic for patients that I've worked with. And I think other issues for after delivery are checking in with these individuals frequently. They are at a very high risk of relapse and overdose after delivery. Do they have naloxone to go home with? If they want contraception, has that been addressed? And it's not to say that when a woman comes in and has a baby and she's been on methadone, we should never make her feel like that shouldn't have happened and that she shouldn't be allowed to consider additional pregnancies on her medication. So a very patient-driven discussion about, hey, where do you see yourself in the next few years? Is having another baby soon something that you're hoping for? And if so, how can we help you achieve a healthy pregnancy instead of how can we make you feel like you don't deserve other children? And access to parenting and postpartum education. I've seen that some of our patients really haven't had access to, here are ways that you can calm a fussy baby. Here are reasons to take the baby to the pediatrician. And here are ways for you to stay healthy when you go home as well. So I think if you have peer recovery support groups or anything that we can especially start to design online, we should start thinking about, especially in the context of the pandemic. So I will stop right there, if that's okay. I do have a case, but I want to open this up to any questions that anybody might have first.
Thank you, Dr. Cresta. I have a question. There was a slide early on that mentioned the challenges around retention for long-term usage for women. Can you talk about that a little bit more and say, I'm just curious, there were two different slides on it, but I'm curious about the first one that was around treatment retention.
So for buprenorphine in particular.
Mm-hmm.
So that really, that line as a disadvantage comes from the mother study that was done in the early 2000s where they did head-to-head. So women came in, they were interested in treatment and pregnancy, and we actually gave them a pill and a liquid, and they didn't know if they were getting methadone and a placebo pill or buprenorphine and a placebo liquid. And what they found is the women who were randomized to buprenorphine left the program a lot. And having participated with that, a lot of it was that study didn't focus a lot on ancillary treatment. And we talk about medication-assisted treatment, but now we're starting to lean more towards medications for addiction treatment. So it's part of a comprehensive program. And my experience is we could actually tell in that research who was getting buprenorphine and who wasn't, because there was just less of a sense of ease, I guess. The women said, I just don't feel as good. And I think that sometimes with that partial antagonist, that can be a concern. So there were more women that were placed on buprenorphine that left the program than women who were initiated on methadone. Now, I would say in my experience since then in actual clinical programs, women who pick the medication that's right for them are much more likely to stay in treatment. And I think the problem with the randomized studies is an individual is told this is a medication you will get, and not here are the options we have and where do you see this working in your life. So that's the first concern I have with kind of saying there is decreased retention to treatment. Unfortunately, that is the data. Those are the data that are advertised when we talk about this at an academic level, and it can be frustrating.
Thank you.
Mm-hmm. Any other questions?
Sorry, I did have one more question.
Yeah.
So I'm curious about that comment around COVID and just like how it sounds like, you know, there's a lot of interaction with hospital or the clinics, especially with the dosing and then also the prenatal. I'm curious if there's been any adjustments to that with COVID or how that's been managed.
Yeah, I think the unfortunate reality is we've all sort of learned as we did this, and there were a lot of unintended consequences of the goals of the hospital to keep people safe. And I think that one of those unintended consequences was prioritizing other health urgencies over addiction medicine. So there are some inpatient programs where pregnant women weren't admitted at the same with the same ease that they were before. We have historically had problems with coverage for telemedicine, and so that has been a challenge. There is this stigma about starting addiction medication that you can't ever start that not in person, even though there are so many other medications that, you know, we prescribe antibiotics for people they might have a very serious reaction to via a virtual visit, but not start somebody on buprenorphine. And so I think that my concern is that addiction treatment has sort of been left as an aside, like we'll deal with that after we figure out what's going on. And one of the things that we're seeing in the data is that opioid overdoses are skyrocketing across the country because individuals can't access care or they're very scared to access care. And when you look at my patients in particular, if you are Black in Minnesota, if you are Indigenous in Minnesota, you are dying of COVID and you are having more severe complications in pregnancy. I can't imagine how scary it is to try and come to the hospital with the information that's out there right now, because no one is being told that they're going to be cared for safely. And I don't say no one, I should say, but this is a very scary time for our patients who are already scared and already distrustful of the healthcare system. And that is something we have to figure out how to deal with.
Great, thank you.
If you do have, I just wanted to say, if you have questions, you are welcome to type it in the chat and we can read those, or you can just wave your hand around and we'll try to kind of watch for that. Either one is fine.
The other thing too, and I think Dr. Grant had kind of mentioned this in the chat, is that we do have a pregnancy-specific waiver training that's happening on October 2nd. Unfortunately, the grant that we have for that, it is $25. So it's the one that Hennepin is doing is free. So I think that's even better. I wish we could do that. But ours is going to be specifically OB focused. So in general, especially if you have providers who want to look at this more from a pregnancy aspect, I think that's it'll also be completely virtual, the half on a Zoom with Dr. Grant and myself, and then half that you do ahead of time, but it will be specifically focused on OB. And that is October 2nd. I believe it's from 8 to 12:30, but we can share that information as well.
I have a question here from Cheryl. She's wondering if there are some hospitals that are doing better with labor and delivery with moms on MAT.
Yeah, and I think, I think Dr. Robbie can weigh in on this as well too, is I don't know that there's one system that is doing kind of a center of excellence type job. And I think the problem is one comment from a nurse, one comment from a doctor, one look can make all the difference. And that can be even more complicated when everyone who comes in your room is wearing a mask and an eye shield to understand the emotional context when people are saying things. And so we are doing ongoing work to try and make sure that we have patient-centered, stigma-free language. But I acknowledge that there's still work to do in my health system. And I think that holds true for all of the health systems. So I'd love to say, yep, my system is, you can come to my system and we have it down. I would like to see, much like we have, baby-friendly breastfeeding accreditation, some sort of stigma-free accreditation that all of our staff has been trained in the right language to communicate with our patients and families. And we're not there yet, but in my sort of pie in the sky dreams, hopefully someday we'll have some sort of training like that we can, for those who are interested, because I know it has to be voluntary for people to really truly engage in the change. But there's a lot of work. What I encourage the patients to tell me is, what was your experience with your prior births? What things were really hard? What kind of language was used? What kind of behaviors did you see? And then encourage them to come back to me, even if it's me that's using that language, to say, I can't get it better unless you call me out. And it's not your job to call me out, but if you see things or you are made to feel like there's something wrong with you for having this medical condition, please bring it to our attention, because I can't always be there to know what's going on.
And I will say, and not just because Cresta is here today, that over the year I've been doing OB care at NAC since 2011, and there's definitely been a transition. And at this point, I do tell our patients that our patients tend to have a good experience at Fairview. And that's definitely been an improvement over the years that I've worked with the clinic systems or hospital systems.
So there's one other question. How long is a typical post-delivery hospital stay? So it's different for every baby, but I would say in general, a good ballpark is 2 weeks. And so I tell patients, be prepared that your baby, how can we get you mentally ready to know that you're going to leave the hospital without your baby? And if you have had a baby removed from your custody before, that is traumatic. And so how can we be ready for that? How can we support you? And then also, maybe there's an individual whose family or close friends don't know she's struggling with opioid use disorder. What are those people who see you on social media say, hey, why is your baby still in the hospital? Why are you here? Can we come up with a good, I don't want to say a story, but a good preparation for her and for her family to kind of say, like, it's your right to say why your baby's in the hospital, and you may not be ready to share that information, but I want you to be prepared for it. I have had several patients who were unable to remain in recovery after delivery because they had encounters where they got called out on social media for, why is your baby still in the hospital? What happened? What's going on? And it was really devastating for them and for those of us taking care of her as well.
I just noticed that it's 1 o'clock. Oh my.
I am happy to come back with a case later. I have cases that I can bring back for another time.
Yes, we would love for you to come back and bring us a case, and maybe even that's the very same one. Thank you so much.
Yeah.
All right.
Cresta,
Well, thanks, everybody.
Do you want to stop sharing your screen?
Sure.
And then everybody can see everybody.
Okay.
Sure. All right. Is there anything else? You can certainly reach out to us. Deanna sends out lots of emails and things. So you can, if you have specific questions or concerns or comments, you can send those to Deanna. Our next session is on, September 2nd. And we'll be talking about toxicology screening, urine drug screens, oral screenings, things like that. Thank you all for joining us.
Miigwech, thank you.
Miigwech, thank you.
Take care. Thanks for coming.